Now we're recording. Now we are live. Good morning, everyone. It's 9 a.m. on a lovely Friday morning. And this is MED265 meets 9 a.m. And I will be posting your midterm. I'll be sending your midterms. We had a little trouble last night with our scanner, but that has been fixed. So I have a nice PDF file, and I'll be sending it via email, your midterm results, because I've been getting calls that you guys can't see your grades or see a posting of your midterm grades. In theory, you should be able to see it in your self-service portal, but I've been getting a lot of calls from other students that they can't see it. Let's see now. Let me see. Go back to 265. So that'll be later today. Right. So now we're going to switch gears. The first half was EKG. So this is actually like a combination class. So the first half was EKG, and it culminated in a midterm that was all EKG. Well, your future final, which will be in week 10, or even if you want to come in week 9, you can. I'll also be putting the laboratory. And again, if you can't make the laboratory, I need to know as soon as possible. This class doesn't really get affected. There's only 3 of you, but if you can't make it, I need to know, especially if all 3 of you can't make it to the lab sessions. I have to have other things that you can do so you can at least garner some credit and some attendance. Okay, but just know that this is a very laboratory class, and it is in your best interest. Now, let's say you can't take the laboratories on those particular days. Again, shoot me an email. We already have a couple of Friday sessions going, and I'll get those options as well on your announcements. So let's just jump right in. What's due today? Of course, week 5 discussion, week 5 quiz, and take a look at your quizzes. I've gotten reports back, not from this class, but the Thursday class, that, hey, I did the quiz, and then I look and it says incomplete for whatever reason. But the student just shoots me a screenshot that shows me a completed grade, and then I'll amend the grade. But that's the other class. I don't see that issue here, but just check over your quiz grades. And let's say you didn't get a flattering quiz grade, like you got something that was a little low. I've already taken off the no repeat option. You can repeat your quiz as many times as you can. So what I suggest is, if you know how to screen record, you take the quiz and all the ones you got wrong, that's how you learn. You write them down, you research them, get the correct answer, and then go back and then retake the quiz. Actually, that's a lot nowadays for continuing medical education. In the past, they only had like one-off quizzes. They still have that for the last final quiz, but all the mini quizzes that lead off to the large quiz on your future continuing medical education classes, you can take them as many times as you can. And it's really neat because it's also a way to study and a way to practice. So right off the bat, I'd just like to review real quick what phlebotomy is, and also we'll be doing parenteral medications as well. So first, we need to remind ourselves the difference between arteries versus veins versus capillaries. And what's a nice picture? Oh, this one is the one I use in anatomy. So we look at this picture here. Arteries are typically blood vessels that the red blood cells are carrying oxygen, mostly oxygen, away from the heart. And veins, and they're colored red in textbooks, so you know that it's an artery. In real life, you know they're not colored red. They're 18 shades of brown and gray. your insides, if you recall your anatomy and physiology dissection. And another thing is veins are colored blue. They have valves inside that prevent backflow. The arteries are under high pressure. The veins are under low pressure. And if you look, the main difference is if you look at the tunica media or the middle section, you could see it doesn't have a muscular wall. But if you look at the artery, it has a muscular wall. So that's where blood pressure comes from. It comes from arteries. So when you're trying to read somebody's pulse or trying to do somebody's blood pressure, you're looking at arteries. Well, veins, we're looking at phlebotomy. And veins are more superficial, arteries are deeper. So when we're doing phlebotomy, which is what we're going to be learning today, tomy, to cut into vein, when we get blood for blood tests, that's venous blood. So the blood that comes out in the tubes should be colored like maroon or dark brown. But if you've ever been to an accident or been a victim of an accident and you have one of your arteries got cut, it's bright red. Okay, so arteries, oxygenated blood away from the heart, veins, deoxygenated blood coming back towards the heart, right? And this is what we do phlebotomy on. We also have some blood tests to do the to utilize arteries, but that's beyond the scope of what you need for medical assisting and even nursing. I've been informed that nurses don't do ABGs anymore. And ABG stands for arterial blood gas. And remember, red, think oxygenated. Blue, deoxygenated. Now, even thinner than an artery and a vein is your capillaries. And if you see here, your capillaries are a mixture of oxygenated blood and deoxygenated blood. So this is the area or areas in your body where there's gas exchange, because capillaries are very thin walled. There's a mixture of oxygen and carbon dioxide, and there's pressure gradients of carbon dioxide and oxygen going in and out of here. Okay, so know these differences. They're classic, and there's also these lovely charts that you could look up, and this is the thing that we talked about: thick versus thin walls, arteries versus veins, right? Arteries are, of course, high pressure. Think blood pressure. And veins, low pressure. Okay. Large amount of elastic fibers in the artery because it's under high pressure, right? And who has valves? V for valves, V for veins. Okay. There's a nice little, and all you have to do is Google arteries versus veins versus capillaries, or look in your textbook under vasculature, which I believe is like, I don't know, chapter 9, 10, or 11, around there. So let's jump right in here. Of course, let's do next week. Side effects of phlebotomy and how to deal with them. And you got a little homework here for week 6, and that's due, of course, next week. So let's jump right into chapter. And this is taken from an old textbook that we used to have a couple years ago. And we now already defined phlebotomy and what does phlebotomy do for us. Phlebotomy gives us the ability to sample our patient's blood, and it's venous sampling. So it's venous blood. And we're going to be talking about the competencies or the actual, how to do the procedure. And of course, there's a set of communications to your patient, communication to your doctor, communication to your lab. That's kind of important. Another word that they use for phlebotomy is venipuncture, okay? Because I'm puncturing the vein. And phlebotomy, tomy, means to cut. And if you've ever seen up close, not a cutting needle, If you've ever seen a needle up close, let's look at it. Where's a nice picture of the tip of a needle? Ooh, look at here. If you've ever seen, no, I don't want 10% off of purchases. If you look at this, do you see the needles? They're like little knives. You see how it's, and the tip right here, that's called a lumen, right? Or the hole. And you can see there's different colors. We're going to be talking about those different colors because those different colors match up to this here, which is gauge, which is the diameter of this lumen. And you could see why we call it phlebotomy, because the needle kind of cuts not only into your skin, it cuts into your vein. Hence the term phlebotomy. And they're all different sizes. And how do you know? You even look at them and the colors give it away. Okay, and you can see here, 27 is gray. I think 25 is blue. Yeah, 25 is blue, 26 is tan. And we do that especially in emergency situations. So you don't take precious time reading the box. You can just look at the color. And the same thing with the color top tubes. You could really easily identify it. Okay, so that's what phlebotomy is. There's my notes. Now, there are phases, and this comes out in your RMA, CCMA exams. I was kind of surprised to see this. There are steps, and there are phases. So you have the pre-analytical phase, analytical phase, and the post-analytical phase. Now, what does that mean? Now, pre-analytical phase, we're going to be talking about, you have to have an order, okay? Whether it be verbal or written. The doctor or the nurse has to tell you, yes, we need this and this test, okay? We, of course, use standard precautions, which are now enhanced because of COVID, right? We have to have patient prep. And the number one thing, identify your patient. Remember the two things that we always use as identifiers, right? Last 4 digits of the social security number and or the date of birth, okay? Of course, we have to perform the procedure. Labeling, we'll be talking about how to properly label the specimen. Because if you don't properly label the specimen, remember we just talked about communications to your doctor, communications to your laboratory. That's when things get messed up. Of course, transport the specimen. Can I put specimen in my pocket and walk around? When I was in MA, I used to have this bad habit of putting specimen in my lab coat until one morning I came home from work, right? I used to do like morning shift and then come back later for an evening shift. I used to have a split schedule. And I went home for lunch, and guess what I found in my pocket, right? I found a blood tube that's, of course, unlabeled, right? So I got in a little bit of trouble for that. How do you fill out the paperwork? Where do you store it just in case, because if you've ever seen those little milk boxes on the outside of doctor's offices, that has, what do you call that? Sometimes they don't pick it up, right? Or if you don't call the laboratory for pickup and confirmation and you don't get the confirmation number, that's on you. And you put that specimen outside. Now that it's cold weather, it's not too bad. But again, that's really bad news. It causes a lot of laboratory and reading problems, right? And also, how many times have you ever put something in your refrigerator, all the way in the back of the refrigerator, and it froze? If you do that and the specimen's frozen, it causes problems. I had a nice habit that I had when I was a medical assistant. I put it in the door, on a rack, on the door of the, or on the front part of the designated refrigerator. And remember, it has to be a designated biohazard refrigerator. And according to OSHA, We cannot, and remember OSHA, Occupational Safety and Hazard Administration, can I put my sandwich right next to this blood? No, I cannot. So I remember once I was in lab, I found somebody's ham sandwich in a biohazard. That's a big no-no. Again, we talked about communicating, right? And we don't want a communication that the specimen is unacceptable. That's called QA or QI, quantity insufficient. QA is something else. QA is quality assurance. So QI is quantity insufficient. Now, many laboratories use that acronym also to state that the specimen is unacceptable. Let's say, for example, it froze over and it's in a chunk of ice, or there's not enough sample, or it's in the wrong tube, or the label is put wrong. So that's something, and that's a part of this processing. And did you deal with a stat specimen? And remember the medical terminology, STAT. Stat means to be done not only immediately, it should be sent to the lab immediately. Do not wait. So that's the pre-examination process, the pre-analytical phase. That's the stuff that has to happen, that you have to prepare yourself before we actually do the actual process of getting the blood. So that's the analytical phase. So did I use the proper method? And we're going to talk about the method today. We're going to talk about the equipment. And every test has a specific kind of tube that it should be performed in. So if I do test A that doesn't match the proper tube, we got trouble. QC or QA, which is quality control, quality assurance, because are we sure that the test is the test that we want to do? Okay, and that's quality control. And just like if you recall your pharmacology, if you recall your pharmacology, remember you had to have the right drug for the right patient for the right timing. Well, it's the same thing with getting specimen. Is it the right equipment? Is it the right patient? Is it the right timing? Am I supposed to be getting this blood now? How many times did I write when I used to work as a physician? How many times I used to write the word postprandial administration of phlebotomy, and then they take the specimen either while the patient's eating or before the patient's eating. Postprandial means after, right? And how many times I've seen that and caught that, and it ruins the laboratory results. Of course, troubleshooting, and the reagents that they're talking about are the chemicals that are inside the tube, which is what we're going to be talking about in a future lecture. Not all of those tubes are empty. It may look empty, but there are chemicals inside it. That's why you try not to open up the tube or look in it, or if there's a crack in the tube, you really shouldn't use that tube. Or if the tube is, the blood tube is expired, there's expiration dates, and there's expiration dates on it because there are chemicals or reagents in there. Okay, so you'll be doing a lot in this analytical phase. QC, also known as QA, quality control, quality assurance. Are you providing a quality specimen to the laboratory? Right? You review and you verify your results, and that's also important as your role of medical assistant. If you have funny results or any results that are flagged, what I used to like doing is I used to actually print out the lab results, or nowadays you can do it on your electronic medical records. You highlight it and you tag it so that the doctor sees it that day. And also I usually link it with the patient's chart. So if you're in a mom and pop place, take the actual lab result, print it out, put it in the actual patient's chart, let it stick out a little, and put that on the doctor's desk so the doctor can go read it and then verify the results. Okay, especially if it's an abnormal result, and help the doctor out. Nowadays, a lot of the electronic medical records and lab results, they color code it already, but I like just taking a red pen and circling it. Just to bring the attention to the doctor, just to bring their eyes right to the problem. Reconciling any discrepancies. Okay. For example, if you said test A, B, and C, and the laboratory gave you A, B, C, and D, you have to call the lab and say, hey, where does D come from? Okay. Because also remember, that also has to do with billing. Because if we only ordered A, B, and C, and the lab is charging us for A, B, C, and D, that's on the patient and on the patient's insurance. How many times, I'm not saying the laboratories are shady, but they're a business just like anything else. Sometimes they add little things, and you just got to pay attention. And then also remind the laboratory, hey, look at the original requisition form. The doctor didn't order that. The doctor didn't sign off on that. Can you please amend that for your records and amend it for our medical billing, right? That's the kind of thing you're going to be doing. And TAT, turnaround time, that is huge because especially for stat, this is one of the metrics that the laboratory lives and dies by. How fast from when the laboratory was ordered to when you administered the laboratory and got it to the lab, that is the TAT for us clinicians. And the TAT for the laboratory is how fast did they get back, give our results after we formally submitted it. So TAT, turnaround time. And for us, from when it was ordered to when we shipped it out. And that's a big thing that the office looks at. All right, last but not least, the post-analytical phase. That's what? The actual reporting at the very, very end, right? We check, do we have a good TAT? Do we have a good turnaround time, right? Again, what I mentioned here, make sure you flag, right? Because any issues, and that's post-analytical. And correct any erroneous results. So think analytical is the stuff we do the day we did the lab, and post-analytical, the stuff we do when the lab comes back. Any troubleshooting, obtaining information needed for follow-up. Do I have to repeat test? Let's say, for example, I circled something and the doctor goes, I don't like it, call her back in. I immediately jump on it. I have to call the patient back and said, hey, you know, no worries, but the doctor would like to repeat the test. Okay, it's annoying, but many times, especially if it's something serious, I'd like to look at it again in a couple of days. Another reason why we retest is, let's say, for example, my patient's on Coumadin. I don't like the PT-PTT or the bleeding study that was done. I want to repeat it, and I want to repeat it today. But typically for, if you're on like warfarin, Coumadin, and all that jazz, it's typically every 72 hours or so. Now, this is what the lab team kind of looks like. It's headed up by the Department of Pathology, and you'll see the different kinds of tests that you can have, and the staff is broken up into teams, okay? So the Department of Pathology, they do the labs, and they have a subsection just for specimen and collecting. And these are the medical these are run by medical technologists, head up by an MD or an DO with a specialty in pathology. So we have chemistries, or the chemistry tests. I just mentioned the coagulation studies, PT, PTT, which stands for prothrombin time, partial thromboblastin time, and we're going to talk about that when we talk about tests and tubes. Microbiology, parasitology, we have somebody looking at microscopes to look at any buggies that we have. Immunohematology or serology, we look at the serum of the blood, right? Because what's in the serum? You got a lot of immunogens, a lot of immune proteins, also known as immunoglobulins. We have a lot of antibodies in there. So when we're looking at to see if you have an antibody titer, these are the people who do that. And of course, you have the urinalysis, and then you have a separate team just for stats or ER stuff. And a doctor's office, in the office setting, we could do ER and stats. Let's say, for example, my patient just coded right in front of, right in our waiting room. Sometimes the doctor would like to take bloods and take stuff there. It's rare, but it does happen. And especially if you're in an urban environment. It's happened to me half a dozen times when I was an MA. But again, I have to remind you guys, I was an MA in the middle of uptown Manhattan, New York City in the 90s, in the height of the crack epidemic and the AIDS, HIV epidemic in New York City at the time. So we had a hardcore environment. On any given 5-hour shift, we could see up to 80 patients. And we used to work Monday, Wednesday, Friday nights, and Saturday mornings. So you can, if for those of you looking for externships, that's the kind of externship you want, the kind that's lively and does a lot of things. And when I was working that, before I got into surgical service, that was really, 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 really busy. Okay. So what is our duty? Again, we have to communicate. We have to identify the patient. We always assess the patient. Should I be taking blood from this person? Okay. You have to assess the collection site. If there's a whole bunch of scars or scabies or dermatopathology around the injection site, should you be touching that area? No, of course not. How to prepare your patient. Go back to your MED 140 notes on how to deal with your angry, perturbed patient, how to deal with your nervous patients, right? And draw the blood, put it in the proper tubes, in the proper order. We're going to be talking about the color top tubes and the order of draw. And of course, after you're done, you make sure you get them back to homeostasis. And if they're still bleeding, you gotta be able to control that bleed. And if you can't control the bleed, inform your chain of command. Okay. And the biggest thing that we have to watch out for is syncope, fainting. Okay. And I can tell you right now, from the tens of thousands of patients, you'll kind of know before they faint. They're very, very nervous. They're very, very focused on your needle and your equipment. Many times they could either be super talkative or super quiet. And for me in the ER, 9 times out of the 10, it was the biggest, most macho, most burly man, usually fire department or police, and they're staring right at you. They're pale as a sheet, and it's obvious that they're very afraid of what's to happen. And then we'll be talking about in laboratory how you situate that patient so that they don't fall on you with a needle full of blood in your hands. Of course, be able to manipulate the object, small tubes. This is nice to know. I don't know why I ended, right? This is the stuff that we talked about, and be able to answer questions or queries, especially when it comes to side effects. So that's your discussion for this week. Look up the most common side effects. How do you deal with it, right? Many people, when they look at that bruise on their arm, oh my God, the tech messed up. No, they didn't. And on your discussion, you should be able to answer why. Why is a hematoma not a mistake and a predictable side effect? Okay. Safety in the laboratory is prime. Safety for not only your patient, but for you. And with all the enhanced COVID stuff, the hospital and even the office setting, you're not only gloved up, you're masked up, and you also shielded up. And there are many mask shield combos. Okay, you've seen them on TV. And also many hospitals, a lot of the techs now are all gowned up. They have full gown on, full surgical gown on top of their scrubs. That is the new norm. That is where we're living in right now. Sorry to use that hackneyed expression, the new norm. I hate living in these difficult times. Ugh. My God. Those of us who are from a developing nation, this ain't difficult times. Come to my home country, the Philippines. This is dengue season. My daughter is in the Philippines, and she helps out there in the local hospital. They have 63 pediatric dengue patients. Estimated a third of them will probably die by the end of the week due to hemolysis, right? And we're all stuck on COVID. Silly, silly world we're living in. But it is what it is. Infection control, big, big, big. because remember, our skin, right, is teeming with stuff, dermatophytes, Staphylococcus aureus, Staphylococcus epidermidis. So we have to have some infection controls. And remember regarding the safety, we remember your universal precautions. We must assume that everybody, including ourselves, including our colleagues, including our patients, including the lovely lady who does sanitation for our room, all of us are HIV positive, and all of us are, that's what you have to assume. So if you assume that blood and human body fluids are toxic waste, then you have to act accordingly. So have your PPE, right? Glove up, mask up, gown up, according to the protocols of your facility. I just visited a friend of ours in an assisted living. It looks like an OR. The whole place is all covered in plastic. Everyone's gowned up, got the little booties on. Everyone's got has not only mask but has a face shield. When we visited them, we all had to be masked up, and we only had limited visitation time in a public open air area. And that's how careful they are, because that is a high risk place. Fire prevention control, dress code, attendance. This is nice, you know, I don't know why the textbook added that, but these two things, safety and infection control, that's the two biggest policies. And of course, with your laboratory results, another thing I forgot to mention that was on an exam once, they talked about HIPAA. HIPAA compliance is all over the place, but HIPAA, which is the Health Information Portability and Accountability Act, the test results are big on HIPAA. So if they ask regarding HIPAA, regarding can I talk about the lab results to anybody, the only people you're allowed to talk to the lab results was the person who ordered it, and goes, and the person who's gonna the person who's going to put it in your electronic medical records. You shouldn't be sharing it with buddies and friends or other colleagues who have nothing to do with the case. Okay, put the laboratory, put it in EMR. If you're not good at computers, you better get, because the whole world is electronic medical records now. And there's considerable training on it, even in the office level. When my wife was an office manager, they had something like 3-4 hour sessions just to learn all scripts, and it is a variant of Epic that's for, I forgot what it was called. Ugh, I have no brain. But that was the electronic medical records, and they only had like 4 MAs in that office, but they had considerable amount of training regarding electronic medical records. Now, okay, this is really important, and we kind of touched on this a little bit. Remember your MED 140 training when we talked about verbal versus nonverbal cues. Remember, I just mentioned the nonverbal cues that you have for your nervous patient. They're focused on, they're nervous, they're focused on your equipment, right? And of course, they look like they're in fight or flight. Listen to your patient. If they tell you, oh, it's not so good in my left arm, right? Give them the benefit of the doubt, because especially if they're like a dialysis patient, they know stuff that you don't. They've been poked every 3 days for a considerable amount of time. So listen to your patient. Take a moment. Telephone etiquette when you're calling the laboratory. Just like in MED 140, always address yourself. And this is what it's going to sound like. Hi, good morning. My name is Nelson. I'm calling from Dr. Cassidy's office. I go, I would like to know some information about specimen number. And he goes, are you ready? And then you give the specimen number, right? And then, you know, you follow their protocol, okay? Same thing in written communication. Many times on your emails, I always get stuff, I'm going to do work, Dr. Garais. I don't know who you are. And how weird would it be if I just stepped up to you without even greeting you and just started talking? which is kind of actually what I did for this call, but not really. If you look at it, I have to announce myself. So when you're writing your emails and to the laboratory or to the physician or to the patient, make sure that it has a distinct beginning, middle, and end, just like your discussions. Make sure you first have your salutation. Hi, good morning, Ms. Jones. My name is Nelson. I'm calling from Dr. Cassidy's office, and we need the following information to complete your lab form. Or there are some results. When is a good time for you to call the doctor so we can have either on the phone or a Zoom meeting, right? They also have specific training on both these two things when you go into a bigger facility like Inova. My wife had like, I think it was like one whole day training just on the script, on what do you say, when do you say it. And Inova has a script. So if you ever call them, they all say the same thing. Hi, my name is Millie, and I hear it all day when she's in her office. Medical terminology appropriate for your patient and coworkers level. So if you're talking to someone who knows nothing, don't use medical terminology. And remember, look back on your MED140 notes. Look back on how to deal with your angry patient and how to deal with your nervous patient. Those are the two big patients that they always have scenarios on in your CCMA and your RMA. Nutrition, rest, exercise. Oh, this is big for CCMA, RMA, right here. They always ask about the, I forgot what they call it, the communication cycle. So in every conversation, you have a sender known as an encoder. So something sparks the sender to say something, right? Some stimulus, right? So for example, the stimulus for me to talk to the doctor is, hey, there is a flagged report. So I have to give the message, either verbally or non-verbally. And remember, when you talk to people, there's a non-verbal signal. And if you got training, you could pick it up. Like yesterday, remember I always tell you guys I'm the stick in the mud during meetings? Well, I tried to shut up, but at yesterday's meeting, but you know me, when someone says something BS, I got to call them out on it. And the person that I was talking to, I kind of played some games with him, and I started picking up nonverbal microaggressions. So the receiver, right, the decoder, he was picking up that I'm being a little bit on the aggressive side. So what did they do? They encoded my verbal, because I was going, what do you do now? What do you do then? I was, you know, I was being a jerk, and I was having a verbal tone, right? So when he started speaking back to me, what I picked up was he was saying all the right things, but I can see his eyes, right? And I could also see the wrinkling of his forehead, the nonverbal signals that what? He's starting to get pissed, right? Just a little background. He was like a quote unquote efficiency expert, right? But I don't think he was angry, but he was concerned of what I was saying and some of the words. So, and I'll admit I was pushing a little, right? So we use that example, right? So be careful, right? Because it's not only your verbal, it's your nonverbal, right? So what I like doing, even when I'm on the telephone, I like, even if you got your mask on, I like, you know, giving a smile and go, hey. And that's what I did, because my next exchange with him, now that I decoded, right, his message, right, I go, I better back off. And then I did what? I smiled, and I'm like, and then I even said the words, you know what? And he goes, I kind of agree. I partially agree with you, sir. Right? And you see the tone is very different. I use the word sir, right? And not in a like a sir, you know, in a bad way, right? For those of you military in the room, how many times you use sir? In like, yes, sir. And you know, you do it in a little, but don't do that to your sergeants. They'll do something to you back. And it'll definitely won't be verbal or nonverbal. Now, what's this noise, right? Noise is anything that will prevent this message from properly being received or sent. So what is some example of noise? It could be actual noise, or it could be the mask you're wearing. It's very, very hard to gauge people and to speak to people with the masks on. But you could still see their eyes, and you could still see. I had a student, myself and Professor Greninger were talking to her, and I could watch her eyes. I'm watching her eyes roll and watching her attention stray already. And then Professor Greninger picked up on it and goes, "Hey, are you paying attention? Are you listening to me?" And that's what you have to also pay attention to: noise. Another thing about noise is preconceptions. Let's say there's a stimulus. My patient's already pissed off, right? That's already going to start noise, and it's already going to send the wrong message. So when you're think about noise and anything that would interfere with the message or the feedback, and being a good listener in medical, that's the big thing. Look for that feedback, and it's not only verbal or nonverbal. Now I feel bad about yesterday. No, I don't. Yes, I do. Well, I'll make up my mind later. So we all know this and I'm going through this for MED 140. So empathy, right? That's not sympathy. Sympathy is feeling sorry for somebody, right? Oh my God, I feel so bad. That's sympathy. We're not in that business. Empathy, walk a mile in their moccasins, walk a mile in their shoes. Understand that your patient's pissed. Wouldn't you be pissed? Yes. So, sometimes you gotta take the brunt of the complaints a little bit. Always show respect, even though they're not showing you any respect. How many times somebody doesn't call me by my title, which I've earned, right? How many times somebody's kind of pissing me off? But what will I always return, right? Kill them with kindness. Yes, ma'am. No, ma'am. Especially when some crazy Karen or some crazy Ken is in your face, which, by the way, is all day, every day in medical, right? You still show them respect. Yes, sir. Yes, ma'am. He goes, I understand, right? Even though what they're requesting or what they're saying is sheer insanity, you always maintain your calm. You always maintain your confidentiality and your respect, okay? Even though sometimes they don't, but then if they're really getting out of hand, you guys know what to do. I'm very sorry. I have to hang up now. I'm very sorry. It goes, we cannot hear you with you yelling at me and cursing at me. But then you see my tone, right? Keep it professional, right? Keep a professional bond, common courtesy, show some interest. I love when I go into doctor's offices and the front desk is like, have a seat. Doctor will be with you in a minute, right? Even right now, you don't see my face, but you can hear it, can't you? Right? Don't be that person. A year ago, I had I love telling this story. A year or two ago, I had a student who got dropped from the site the very day she signed up. So always have respect and always assume somebody's a doctor or a big boss or a VIP, because this is what she did. It was her first day. She's filling out all the proper forms and the insurance forms and everything like that, and the liability forms that you need for the externship. So she's sitting there, right? And some woman in jeans and a t-shirt comes in and goes, hey, your first day? And this is what my student did. She put up her finger without even looking up at her paper to signal to this woman that that hold on, I'm busy. The woman was the co-owner and the office manager and the wife of her physician. And then I got a call 5 minutes later and to tell her, we don't like that kind of applicant. I don't think we're going to be accepting anybody this term for externship from Stratford. So in just a brief moment of disrespect, she ruined an entire site, which took me 2 months to build that our reputation and our rapport. And just because you can't look up and say, why, thank you, because yes, it is my first day. Hi, I'm Nelson, and you are? You can't do that? Take 2 seconds? Oh my God. And the student was really upset, and it was so sad. And she learned a valuable lesson. Fast forward, she learned the lesson and then did what? She went to another site and did well and got a job. Hey, did we lose somebody? There was 4 of you. I mean, 3 of you a minute ago. Listen actively. Of course, non-judgmental, but you have eye contact and, do that thing. You know that thing like, make that little sound that, hey, I'm listening. And look up at your clipboard. Oh, me and my memory. My face is always down writing something. I learned real quick when I was a medical assistant. Like, you got to look up and you got to talk to your patient. And then, of course, when you're doing that, when you're actively listening, you're also looking for clues, okay, on what they say and how they said it, okay? And provide feedback, right? Look at your patient's posture. It's open, closed. And remember, this is a quick review from your MED 140. So verbal, nonverbal, zone of comfort. Remember, arm's length. That's the only thing you need to know. Arm's length, that's it. Do not violate the personal space of your patient. Do respect their culture, respect their beliefs, okay? Because if they want to wear a tinfoil hat while you're taking phlebotomy, let them, okay? Remember, it is that, I remember what they always say about religion. One man's religion is another man's belly laugh, okay? So respect everybody, even though, they might freak you out. And here's some active listening techniques that I added here, okay? So like I stated, like even though we've had this before, this is definitely going to be these active listening, values versus beliefs, and negative body language, all of these things. This definitely. That's future CCMA and RMA stuff. Certified clinical medical assistant, that's NHA. Registered medical assistant, and that's AMT, for national registries. Okay, and then when you're almost finished with your externship, give me a call for review material. Give me a call for how to sign up for that stuff. So that was, my version of chapter 1, which is also a little bit of review of MED 140. Now let's talk about, before I handle any specimen, I should have put this first. Let's talk about the requisition form. Remember we talked about pre-analytical? I cannot, right? Because I cannot, what do you call that? Perform any phlebotomy unless I have an order. And this is your typical order form. And you should be able to fill this out, and your doctor needs to sign it or stamp their TrueDat. Let me show you what the TrueDat is. Remember the little stampy thing. Oh, TrueDot. I've been calling it TrueDat for, it's just me and like Chick-fil-A. It's Chick-fil-A, but I've been reading it and looking at it. I don't know, maybe it's the autism in me, who knows. I've been looking at it as TrueDat. It's TrueDot. And it is this thing, the stampy stamp that your doctor has. Now, this stamp, for you and I, civilians now, no big deal. But for the doctor, it has their UPIN number, DEA number. It also has their signature on it. And that is what this is for. Oopsies, wrong thing. This area right here, some physicians just stamp this area. And remember, this form is in triplicate, okay? One goes to the lab, one goes to records, and one goes to the patient's chart. Okay, that's if you're doing if your patient has a patient chart. So that's what needs to be here, okay? And what's important here is either the TrueDat or TrueDot, whatever they call it, the stampy stamp, has to go here, and there has to be some sort of signature. And of course, with the date and time when it was ordered. And you could fill in the date and time, okay? Or fill in all this stuff and make sure your doctor signs it on its way out. Now, if you don't have much time, which usually is the case, I just put patient's first and last name and something, either date of birth, so I know that's that patient, right? And it goes, and or the medical record number. I put the last four digits of the social. That's if it's outpatient. If you're in a doctor's office, if you're in a ward or someplace else, you look at the tag on the patient's wrist, and that's the medical record number here. And for electronic medical records, there's a little Scantron thing. Make sure that gets scanned. Now, another thing that's required is right here. There has to be some sort of diagnosis description or ICD-10 code. And what I do is I usually have certain ICD-10 code go-to codes in my head, like hypertension and sinusitis or rhinitis for common cold, just to put something in there. That was my trick, right? Or if you have electronic medical records, it's usually a drop-down box that the doctor ticks off anyway. And it's cool for electronic medical records. All of this gets filled out automatically if you're running this order through EMR. Now here's all the tests, including the urinalysis that we could order and microbiology tests that we could order. And under microbiology, your culture and sensitivity tests. And remember, culture and sensitivity. Culture, what am I growing, right? Sensitivity, what is a good, what do you call it? What is a good antibiotic for whatever I'm trying to grow? And you could see here, this extra, I don't see this in a lot of stuff, but there's also a space here, like sometimes there's certain medications and you could see here, all of it is antibiotics. I wanna monitor antibiotic levels or pharmacologic levels in my patient's blood as well. So you have all these wonderful tests, and we're gonna talk about the majority of them, right? And some of them we already know. We already know what TSH does, thyroid stimulating hormone. We already know what T3, T4 is. We already know uric acid from MED 140. Of course, I could look at vitamins, rheumatoid factor for rheumatoid arthritis, right? You have your chemistries here, lipid, right? CBC, we're going to be talking about what is a complete blood count, what's a complete blood count with diff or differential, okay? You have ALT, your ALT, ALP, AFTs. Those are your liver function tests, or also part and parcel of your comprehensive metabolic panel. Every time you see the word panel, that means a whole bunch of tests. So if I'm doing a lipid profile or lipid panel, I'm not just doing one just overall lipid total. I'm doing cholesterol, HDL, LDL, VLDL, and triglycerides. I'm doing the whole shebang. So if ever you see the word profile or panel, you're doing like a whole bunch, okay? And here's, of course, blood banking, but typically this is the things. And make sure when you check off these boxes, don't go nuts and go check like that, where some of the boxes start, your check starts violating these other boxes, because when we send this to the lab, it reads all of this, even if it's handwritten. That's why don't do doctor's handwriting when you're up here. Block lettering, all caps, very, very neat when you do this. So the scanner can read it and read it easily. Okay, so this is a lab requisition form. So I could ask questions like, what do you need? You definitely need date of birth and or last four digits of the social. You definitely need an ICD-10 code or a diagnosis description, something in here. You're definitely going to need the ordering provider or the physicians or the clinicians, whether it be the DO, whether it be the nurse. You need their signature here, okay? Because you, as the technician, require orders, okay? And remember what I stated earlier, this could be in triplicate. One goes to the laboratory inside the little plastic bag. One goes to the patient chart, and or gets scanned into the patient chart, and one goes in the patient chart, one goes in the, and there's one more. I think it's for billing purposes, or the patient billing chart. but just know that it's multiple sheets. So press down hard and write clearly. Okay. Did I just kick myself out? Let's go back. Sorry about that. Hello. Hello, online Stratford. I'm waiting. Why did I kick myself out? And why do I have 14 emails? All right, this is something you could do. Close it out. Try again. Okay, so now let's look at the actual procedure. How do you do? And in the laboratory, which is week 8, week 9, and the finals on week 10, that is, and I'll be putting this in the announcements later this morning, February 26, March 5, and March 12. And again, you can't make those dates, but there are other days you can come. Shoot me an email today so we can work everything out. So we got the sample requisition form. This is a rubric, the actual protocol or the actual procedure. So when you look at it, it's a testing sheet. And I'll have this in my hand. And then after you go through this a couple of times for your lab test, I could ask you, what's next? What's next? What's next? And you go do it. And if you fail to do it or not in the proper order, let's say you miss the review of the lab request form or you miss some parts. That's what? -2 points. Make sure to greet your patient. Confirm the patient's identity. Did you introduce yourself and your title? Hi, good morning. My name is Nelson. I'm the medical assistant today. I'll be taking your blood. Dr. Cassidy would love to see your cholesterol and also your CBC, and that's called a complete blood count, right? It was supposed to be fasting. Did you eat anything since 10 p.m. last night? No, I think we should be good, right? Make sure there's pre-test instructions, which is part of the pre-analytical. Make sure the patient is sitting in a venipuncture chair or lying down. And if you're lying down, pick up their head a little bit because, lying from MED140, lying straight flat, especially if you have any upper or lower respiratory tract problems, it's going to be difficult. Did you wash your hands? Did you perform the proper clinical scrub? Do you have gloves on? And we'll add the COVID things here. Are you masked up? Do you have your visor up? Okay. Then prepare the safety and needle holder and adapter. So what's a needle holder? Let's look at the equipment while we're looking at things. Now, the first method that I'm going to be showing you is called Vacutainer Method. Now, the Vacutainer Method, if you could see here, this little gray thing here, once you put a needle in this thing, it's a double-sided needle. So there's a needle out here and there's a needle in here. This thing is called a barrel, right? Also known as a needle holder. And if you could see here, this is an actual needle, and there's a needle inside a rubber sheath that's in here, okay? And this is your safety device. So after we take the blood, when we click on this, it shrouds the needle and protects you from getting stuck, right? So this is the needle, right? It's double-sided. And here is the needle holder, also known as a barrel, right? So did you prepare that? Did you put it in a clockwise direction, which is righty-tighty, lefty-loosey, right? Do you have the proper tubes? And we're going to have that lecture next week. What tubes do you need for what test? Okay. Now, when you look at this, right? You're just going to lay your first tube here. You're not going to fully put it in there until this thing's already in my patient. You can ask the patient if one arm is better or which arm do they prefer, but you as the technologist should then assess to see if that venipuncture site is good. And what should you be looking for? Is there any stent? Or you can feel it. There's a little bit of plastic tubing or something in the antecubital fossa, or that little depression where we take phlebotomy. Let's look at antecubital fossa. This is the area. Ante means front. Your cubitus is your arm, right? Fossa means a depression. And you're looking at these veins. And they're very superficial. The one in the middle is median. The one on your pinky side is your basilic. And the one on your thumb side is your cephalic vein. Okay? So these are your three opportunities within the antecubital fossa. Okay? And there's different variations. Sometimes it look like this. And remember, we can't go deep, because if we go deep, we're going to bump into things like nerves and arteries, which is no bueno. We want to only hit the vein. That's what we're looking for. So I assess, do I see if there's any rashes or any recent scars, any recent tattoos, anything that will prevent me from, oh, Miss Phoebe, that's all right. We'll see you when I see you, and then we could watch the video later. Oh no, she's probably already logged off. Or are she logged off? Okay, so where are we? So that's what you're looking for. Now, ask the patient, oh no, we're already done. Properly apply the tourniquet to the patient's upper arm, right? So it should be applied at least 5 centimeters away from where you're intended to put the needle in. And let's look at how to tie a tourniquet. If you have your tourniquet at home, please practice this.
Hey, this is Sarah with RegisteredNurseRN.com, and today I want to show you how to put a tourniquet on a patient. Whenever you draw blood or start an IV, you'll have to put a tourniquet on, and I just want to give you a quick video on how to do that with a quick release.
Now, if you look at this nurse, right, MA technician or whatever, you see she has a neatly pressed. She has nothing hanging. Her hair is up and no jewelry that will dangle, right? She put some makeup on, but I highly suggest we're not there to look good. And sometimes your makeup is an immunogen for some patients. You shouldn't wear any rings or any watches or anything of that matter. And if you see nurses, they have these clip-on stuff here, right? Not only ID, but also watches and things that you can tell time. But if you're in a ward setting, there's clocks everywhere.
A little practice. So after you watch this video, I would try to practice on someone in your family or a friend so you can get the hang of it. So here we go. First, what you're going to do is you're going to explain to the patient what you're going to do, and you're going to take your left hand and your right hand, and you're going to stretch the tourniquet as far as you can, but being comfortable to the patient to the back of the arm, and you're going to cross it like a shoestring, okay? Have it crossed, and then you're going to take your dominant hand, and you're going to sort of do a little loop underneath this area, and then just leave it like so.
Okay. You see that? She made a cross, and whatever part that you're going to tuck in, you're going to tuck in from the top, because you see these little things that are hanging out. This tourniquet is not sterile. You're gonna try to clean it with you know, little isopropyl, 70% isopropyl alcohol pads, right? You clean it before and after each patient, but after, like, you know, several patients, I forgot the OSHA standard. I think it's after 3 or 4 patients or so. You discard this and get a new one. But if your patient's all bloody and all messy, right, or they have eczema and have a skin problem, discard it. This goes biohazard. You see how it's a good 4 fingers away, which is easily 5 centimeters away from the antecubital fossa, right here. You see how she tied it tight, but not super tight, just enough, right? And this is the hardest part, trying to find the veins. So if you have a tourniquet at home, or you can get one in CVS or Walgreens, practice this, because this is the hardest part of phlebotomy. Sticking that needle, that's the easy part. Getting the blood happens at this stage.
And then you start your IV, draw your blood, and then when you're done, do the quick work.
You can also tell that this is an old video because, oh, look at this, bad, nursey. See this? All that white? It should be down to the nubs, right? There's a little bit, well, maybe they're not, maybe it's a...
And you're just gonna pull it like...
And also, shouldn't be touching this area. That's the area you're gonna do business, right? Now, let's play that again. You see how it's quick release?
Comes off. And now I'm going to show you how to do it really fast, because that was sort of slow motion. So this is what it looks like whenever you do it naturally.
And then tuck it in, away. And then when the thing that you tucked in, that's the thing that you pull, okay? And you see what she did, and she didn't, she may be explaining it. When you pull it, you don't pull it towards this way, pull it up and away, because you don't, especially after you've done your business, you don't want it to drag around this area, which is your operative area, because essentially what you're doing is you're cutting into the patient's skin and vein. So that's how you tourniquet, and it has to be, and 5 centimeters is the standard. You may see that on exam. I saw it on an RMA reviewer once, and that's why I keep on saying 5 centimeters. Now, the maximum time you can have this tourniquet on is 60 seconds or 1 minute. If you leave the tourniquet on for more than a minute, you're going to get hemoconcentration. Now, what does that mean? Your red blood cells are going to start backing up, and then you're going to have a false positive for polycythemia rubra vera. Now, that means that there's way too many red blood cells, and it'll be a false positive. It's not because you have some sort of red blood cell pathology. It's because you left the tourniquet on too long. And also, let's look at it practically. Leaving a tourniquet on too long, that's painful, okay? So you only have a minute. And when you think about it, look at the minute. It's a lot of time. So you have more than enough time to get the blood. So once you put that tourniquet on, the clock is ticking. You palpate the proposed site with your, it goes with your second and third digit. Do not use your thumb. You're trying to locate the vein. You're going to try to, and practice this at home. You're going to try to find something that feels like spaghetti, right? You cannot draw blood from an artery if you're looking in the right place. Arteries are very deep, right? And your median cubital vein, your basilic, and your cephalic veins are very superficial, okay? And at home, practice on a male patient, a young male patient. That's easier. And then move on to more bigger people, and move and try to find, you know, the biggest, most obese person in your family, and then do this protocol, and that's how you know. Or you can come to lab and try to palpate my veins, which are the hardest ever. If we were an on-the-ground class, I am the final examination. But on the exam, if you can't get a vein, it's only, if you can't get the vein, it's only minus 10 points. Now, we don't use a cotton ball. We use antiseptic wipes, which is 70% isopropyl alcohol. We use a circular motion. So let's say this 48 is where my wound site is. I start in the middle, concentric circles, and I move on the way out like that. And I cover the entire antecubital area because if I can't get the median vein, I want to find the basilic vein. If I can't get the basilic vein, I also want to hit up the cephalic. So again, on any arm, on any draw, you have 3 chances. Only remove the cap from the needle when it's already in the needle holder, when you're ready to perform the phlebotomy. You ask the patient to tighten their fist, right, to make a fist. You also put the other patient's hand in a fist and put it underneath their arm. And I'm going to show you how to do that in lab. Now, you insert the needle. You move relatively quick. If you move slowly, it's painful to the patient, okay? And also some blood might come out, and that may freak out the patient sometimes. You're at a 15-degree angle. That's to assure that you're going to hit a vein. You will not hit an artery or a what's it called? A nerve if you're going at such a shallow angle, which is a 15-degree angle. Okay, you'll feel some resistance, and then it'll be a give, right? It'll fall. It'll fall. All right. So up till number 11, that's the thing that you should be practicing at home, right? Up till stage 11, because that's the hardest part. Because once you identify the vein, all this other stuff is all downhill from here. You fill each tube in the proper order, and that'll be the lecture for next week, right? And I'll show you how to switch tubes. And then once once the blood flow is steady, here is the thing. Remove the tourniquet. Have the patient relax their fist once the blood comes through. Because if they don't, it's going to come in slow, and it's going to take this process much, much longer. Okay? You withdraw the needle, you place a sterile 2x2 gauze, right, over the insertion site. You have the patient hold that gauze in there in place for 1 minute. You check again after 1 minute, and the bleeding should stop. If after 1 minute the bleeding doesn't stop, you ask the patient to hold the original gauze in place. If it gets a little bit more wet, put another gauze on top. You do not remove the original gauze pad because it will remove the platelet plug, and then your patient will start bleeding all over again. And then so if it's still bleeding, you have the patient hold it above their heart for 1 more minute, okay? And then after that, you check again. If the patient still is bleeding, then you just put enough gauze. Don't leave your patient alone. Inform your chain of command that your patient's still bleeding, because they could be on Coumadin or warfarin. They could be on some sort of blood thinner. Now, when you withdraw the needle, immediately you activate should have kept this picture up. Immediately you activate the safety feature. This thing. This orange thing. So if there's a needle in here, if you move this orange thing towards the needle, it will click in, and then it will secure the needle. Do not do it with your hand, and I'll show you that technique. You do it on a hard substance away from your patient. That's why you ask your patient to hold the gauze down for you. Make sure the collection tubes are properly labeled with the, oh, I forgot to mention this. The barcode for the collection tube, like this, see this barcode? It should be aligned. See if they have a picture of it. Here you go. See these barcodes? You make sure one of them is Well, there's always at least one, and also there's also a barcode on your requisition form. Make sure it's aligned this way, the long way. If it's a little off kilter, or if it's not neatly put so that the barcode scanner doesn't label it, the laboratory, if it doesn't scan, it'll just send it back to you as QI or quantity insufficient. And that's no good. Don't do that. So see how nice and neat that is? And usually at bedside, there's in most wards, there's a printer. And for the hospital, when they print it out, it's not only the barcode, the patient's name and all the information and who ordered it, all of that is here, nice and neat on this label. So this is the proper way to label your blood tubes. Now, if you're in an old school place and you only have the barcode, at least put the patient's last name and quickly put the date on that tube. Properly dispose all your equipment. Remember, anything that's sharp, like the needle, goes in a sharps box. Any extra tubes that we are using go in the sharps box. Everything else can go in the garbage unless it's blood soaked, okay? So if you just got a little bit of blood on that gauze, yeah, in theory, you could throw it out in the normal garbage. And for my testing purposes, throw it out in the normal garbage. But if it's blood soaked, it belongs in the biohazard. And of course, deglove, wash your hands, and make sure you tell your patient to keep that Band-Aid on. Put the Band-Aid on over the gauze. I'll show you that technique. And then document the procedure. Now, as you're doing all of this, you're keeping one eye on your patient. If they faint or they vomit or anything like that, those things, the post-analytical observations must be noted in the patient's chart. Okay, so that's the procedure, and those are the kind of questions that come out for your, your registry exam. And let's see if we went over everything that we needed to go through. We went over the notes, and let's see if the chapter 6 homework is good. Yep, there's a case study in there, so kindly do that case study as your homework. You can put the submissions here, put it in a Microsoft Word document, please. Make our lives easier. Put your name on the document. Yes, spelling and grammar count and all that jazz. And if you use any outside sources, kindly refer back to it in there with an in-text citation and with a formal 7th edition APA formatted citation on the very, very end. So we went through the requisition form, the actual how to do it, and I'll even post a, I gotta find a video. I wanted to make a video, but I got carpal. Man, what's up with me, man? I'm just falling apart. I can't move my right thumb. So I'm typing with, my other fingers. But hopefully I can able to do stuff. Now, for next week, I'm gonna put in all the other stuff. So remember, I'm the one building this thing from scratch. So I'm gonna be putting more notes and more things here, right? But if you wanna jump ahead, just give me a call to remind me to do this. I'm gonna try to do this by Saturday, by tomorrow. All right, so it is this point I stopped the recording.